Hi, again, Professor Palmieri. I am going to show you how to do a basic cardiovascular assessment. Okay, so your cardiovascular assessment technique primarily is auscultation. So you're going to be using a lot of your listening. You're also going to look at the patient because some heart problems or vascular problems can show color changes and cognitive changes, even if they're having some difficulty oxygenating. But primarily it's going to be listening with your ears with your stethoscope. You will use palpation for peripheral assessment. So there's a little bit of core up here near the heart, but then you're also going to look all the way down far away from the heart also and assess circulation because that does reflect upon the heart. Some pertinent health history that you might see if they have known cardiovascular problems, but it might be their first time ever having, there was always a first time for everything, right? So somebody always is going to be coming in for the first time, and you might be the first person hearing about whatever is bothering them. Some other things that they might have hypertension or high blood pressure, known coronary artery disease. Maybe they've already had a bypass surgery or had cardiovascular stents put in. Maybe they have angina or they've had a history of blood clots. All of those would be considered to be cardiovascular history. Other cardiovascular related problems. So in these populations, cardiovascular disease is more prevalent. So in individuals who have diabetes, individuals who have elevated blood lipids or cholesterol, or their LDL is too high, or their triglycerides are too high, or if they have clotting disorders. Okay, a lot of times you don't know you have a clotting disorder until you get a clot. So just something to be aware of. Some common symptoms that might point to cardiovascular disease: shortness of breath. And immediately you're going to think pulmonary, but a lot of times it can have a cardiac origin. Syncope or fainting, chest pain, leg pain, the feeling that your heart is racing or you can feel your heart beating in your chest. That's called palpitations. If you've ever drank a little bit too much caffeine, sometimes you'll have that feeling. Or if you're really, really nervous about something, you might feel a little flutter up in your throat a little bit. That can be considered a palpitation. And it's not that harmful as long as it doesn't keep going. Like if you're nervous and you have a couple palpitations, it's because you're nervous. But if somebody's coming in and their heart's beating at 150 beats per minute, there's probably something besides just nerves going on there. Diaphoresis is another cause for concern. Widespread body sweating. A lot of times when somebody presents with heart attacks or MIs, sometimes they're very drenched in sweat. Being drenched in sweat can accompany a lot of other things too, but it's just something that you will see in a cascade of symptoms that will be grouped together in patients that present with cardiovascular issues. Fatigue. Maybe they previously could do all of their activities of daily living without any problems, but now I'm fatigued just walking to the bathroom. So those are new findings that the patient would need to share with you, and you would need to ask questions to find out a little bit more about that. Needing to sleep sitting up is a common thing where patients will be doing just fine, and now I can't breathe unless I'm sitting up in the recliner. And if you've ever tried to sleep in the recliner, it's not good sleep. So then on top of that, they have night after night of poor sleep, and that's going to make everything a whole lot worse and snowball the whole situation. Also noticing if they have any edema, and we have a special section just devoted to edema. Edema can be generalized edema, or it can be pitting edema, where you can actually push your finger into it and the skin will sink in. So we'll talk about that a little bit, a few slides ahead. Okay, now I'm going to unshare my screen because I want to talk to you about the auscultatory points that you're going to listen with your stethoscope. Okay, so I'm going to pull closer to Susie. Forgive me, I'm doing this by myself. Hopefully you can see, I have her marked with 1, 2, 3, 4, and 5. Okay. These are all the places that you're going to listen with your stethoscope. So this is the aortic area. This is pulmonic. This is Erb's point. This is tricuspid. And this is mitral. So you're going to listen to all those areas, and listening in those areas gives you a chance to listen near the heart valves. And that's what you're listening to when you hear the lub dub of the heart sounds. Those are the valves closing. So you're hearing that. And that will sound different depending on where you're at. So it'll be really interesting when you go home, listen to everybody that you can listen to. And notice the difference when you move from auscultatory point to point and see how the sound changes. It's some of the points, maybe S1 or the first lub might sound louder than the dub, and it will change as you go through. If you're ever having a hard time hearing this, have the patient lean forward, or you can have them turn onto their left side, and that just brings the heart closer to the chest wall so you can hear it a little bit better. A little practice tidbit is if you can get access to children legally, okay? If you have children in the house, they're very easy to hear everything. Their chest wall's thin. You can hear all their heart sounds so well. And they're usually willing participants, especially if you give them something in return for letting you listen to their heart, or let them listen to yours and get them interested too. But those are your 5 spots that you're going to listen to. So when I'm doing this, I'm going to stick this in so I can actually hear myself and you talking to you. Okay. I'm going to start with my diaphragm. We talked about turning this so that you have the diaphragm and the bell. I'm going to start with my diaphragm, and I'm just going to tell the patient just to breathe normally. I'm just going to listen to your heart. Sometimes I'll tell them, it might seem like I'm listening a little longer than most people because I'm learning. So you can tell them that so they don't worry and think, oh my God, is she hearing something? And get nervous. So just park your diaphragm there and just listen for a few beats. Listen to lub dub. Do I hear lub and dub? Do I hear anything extra? Any swishing sounds? Any extra lub dub dubs or any other special sounds? When I'm satisfied, I just move to point 2. Listen for a few beats. Move down to 3. Move down to 4. And then your mitral area is down here. It's going to be under the breast. Okay. So if you have a female patient and she's got ample breasts, you're going to have to either ask her to lift it, or you can say, I'm going to lift your breast. Don't do it with the palm of your hand. Okay. You might get smacked. So just make sure you warn her first and just use the back of your hand to just gently lift it. If you use the back of your hand, you're less likely to be accused of groping. Okay. So just lift her breast up, park that right there and listen. And when you can hear it well, keep it there and count your apical pulse. If it's regular, so there's no missed beats in it, it's just coming regular, regular, regular. If it's regular, you can listen for 30 seconds and multiply by 2. If it's not regular, you got to listen for a full minute. Okay. After you've gone through all your 5 points with the diaphragm, now you're going to tell the patient, I'm going to listen again with the other side of my stethoscope. You just turn it, make sure you can hear out of your bell, and then do the exact same thing. 1, 2, 3, 4, and 5. Now you don't have to do apical twice. So if you did it with the diaphragm, you don't have to stop there and listen for a minute on the bell. Okay. So that's your actual heart auscultation. Back to my screen. Okay. So what you're listening for, you should hear a lub dub, count the apical pulse, notice if the rhythm is regular or irregular. And then if you notice any other unusual sounds, any swishing sounds, any extra like galloping sounds, like a galloping horse, those are things that you would want to make note of. Okay, now for your peripheral assessment. All right, we're going to assess fingers, toes, and bilateral cap refill. So on this, maybe I should unshare it. I'm going to try to just do it like this. When you are testing cap refill, you don't have to do every finger and every toe. Pick one from each hand and one from each foot. And just take the finger and just compress it and let it go. See how it fills back in? And you can do that on yourself and look how quick it's immediate refill. Okay, so normal, can't say normal, but normal is less than 3 seconds. It may be immediate. It may be 4 seconds. It may be 2 seconds. It may be less than 3 seconds. But notice it, if it's not immediate, notice how long. You might have to do it again and see if it does it seem delayed, then you might have to actually count the seconds. But if it seems like it's immediate, then you know it's immediate refill. Okay, we're also going to palpate peripheral pulses. We're going to start with carotids, but not at the same time. So we're just going to come up here and feel to the side of the trachea. And Susie's are really good. I parked right on it. So she's got a great pulse on that side and on that side. Just FYI, I could not find her radials or her pedals today, and they're turned on. I think she's getting close to her warranty being out. But in a real patient, you should be able to find those easily. All right, so then we're going to move down to radials. You probably know where to find that, just above the thumb. So I find it here, and there's a little crevice you can kind of fit 2 or 3 fingers in. Don't push too hard. If you push too hard, you can obliterate the pulse. And I'm still not finding her peripheral pulses. And I know they're on. So we're going to pretend that I can feel them. You can do these at the same time if you want. Otherwise, you can just reach across and feel that side. I can actually feel it on that side. Maybe just the right side is broken. So if I actually found that on a live patient, I would say that the left was 2+, which is normal, or a 2. The grading scale is down the slide a little bit. I can say it's a 2. And the one on the right is technically absent. So if this happened in real life, I need to go get the Doppler and Doppel that pulse. So I would document a 2 on the left and Doppeled on the right. Okay, so that's kind of good that that happened today while I'm recording. Then you're going to move down and do the same thing with her feet. I'm going to move my camera so you can see me do this. Hopefully this works well. Okay. Well, this is going to work. Okay. Now, on the pedals, to find the dorsalis pedis, you're going to find this crack between the two. You know what? Let's unshare screen. That might make it easier, huh? Bear with me. Okay. So I'm following this crack between the first and second toe up to the arch of the foot, the top arch. And it should be right there. I usually line 2 or 3 fingers up so that one of them will catch that pulse. There can be some anatomical differences in people, so you might have to just move around a little bit to find that patient's pulse. Okay, do that on the other side. We always compare right and left. Neither one of these are working today. And then now Susie doesn't have these, but you can also test posterior tibial pulses. They are on the inner ankle. There's a little bone in the inner ankle, and you're going to tuck your fingers right around that bone. We'll do this in lab too, but you tuck your fingers there and you should be able to feel that. It is not required for you to test both dorsalis pedis and posterior tibial. If you have one or the other pulse in each foot, you've got circulation to the foot, and that's what you want to know. Okay. I'm also going to come down and test capillary refill. Okay. Now, if I couldn't really find either one of these pulses, I would go get the Doppler again and say that the pedal pulses Doppeled bilaterally. Back Okay. All right. For grading the pulses, 0 is an absent pulse, and you should never document a 0 without getting the Doppler. Okay, that's just negligent to do that. So if you say, well, they didn't have a pulse, well, you better prove that there's circulation there somehow. So that's why we go get the Doppler. If it's weak, you can barely feel it, that's a 1. If it's expected or normal, that's a 2. So if you feel your own right now, you're probably all going to have 2 pulses. Okay. And then if you're feeling it and it feels like it's just bounding against your finger, that's a bounding pulse, and you can document that as a 3. Now, the rest is noticing overall color. So I'm looking at the patient's legs, lower legs, because I want to look at circulation far from the heart. Even farther than arms. Arms, most people's arms are good, but where you start seeing problems is the farther away from the heart that you get. So you're going to look for right and left symmetry on the patient. Does this leg match this leg in color, in warmth, in hair distribution? So if you have a man, or even ladies, if they haven't shaved for a while, you can tell if they've got stubble on one leg but not the other. And probably she's going to tell you that I stopped having to shave my right leg. I don't know why. It's probably not a good thing, but you're not going to tell her that. You're not going to get her worried. But it could be because of follicular damage from reduced circulation over the years. It can also happen from things like, depending on what kind of work they do, sometimes their work pants might actually rub the hair off. Could also be just the way the patient is. I have a neighbor friend who has no hair on his legs, none whatsoever. And that's just a variation among people. But you want to notice that. And if you thought it looked different, you can just ask the patient, have you ever had hair on your legs? And they'll say, no, I never did. Or yeah, I used to, but ever since I started working construction and my pants rubbed the hair off, or whatever, they'll tell you what the story is if they know what it is. If you notice any edema, okay, sometimes it can be hard to pick up on. And I have asked the patient before, particularly postpartum patients, because sometimes they look like they don't have edema to me, but the patient will say, oh, my legs are so swollen. To them, it's a lot. And so I ask the patient sometimes if it doesn't look like there is, or maybe I think it looks like there could be a little, but it's not real clear. I might say, do you think your legs look swollen? And no, yeah, they'll tell you what they think too. If it's generalized non-pitting edema, it can be hard to see. But if it's pitting, it makes it a lot easier to see. So with pitting edema, the bigger the dip and the longer it takes to return to a flat surface is how you grade it. So minimal edema would be a 1, and really deep edema that you can put your whole hand in, it takes several minutes for it to return to flat, that would be a 4+ edema. Okay, people can have a mixture of pitting and non-pitting edema. If you notice that it's pitting, you should also work your way up to find where the pitting ends. Okay, so let's say that I notice pitting edema. I'm going to keep, see if I can get her to show up here. Let me get off this share screen. Okay, so let's say I found it here and I'm pushing on it, and don't push hard enough to hurt the patient, but enough to make a pit. Okay, I see it. I'm going to move up a little, try again, move up a little, try again, and see where it ends. So I might say that it's pretibial edema extending to the knee. Okay, so right leg, pretibial edema, 1 to 2+, extending to knee, left leg, no edema. So that might be one way that you can document it. All right, definitely compare right and left. It's not uncommon for a patient to have asymmetrical, I can't say that word today, asymmetrical edema and just other findings, vascular findings down below. Some other things that you might find is something called bronzing. And that's where the legs kind of take on a darkened look to them. They might be kind of splotchy looking. And it can look different on different skin tones. So if you have a darker skinned person, it might look very purple. If you have a lighter skinned person, it might look kind of tan or bronze. It just kind of depends on their skin tone. Also, another thing you might see is flaking. And that just tells you it could be some dry skin, but usually at the level that you're going to see it, you're going to look at that and think there's some circulation issues going on here that have been present for a while. And you can see the flakes just come off, and sometimes it doesn't smell good. So a nice bath will, and I think we've lost sight of bathing in the hospital too. That's kind of one of those things I think needs to come back, is helping patients have some dignity and getting cleaned up. But sometimes your bath in the hospital might be the best bath they've ever had for several years. So think about that when you're taking care of your patients, and try to give them some dignity. But trying to get some of that dead skin off, maybe a little lotion, not between the toes if they have diabetes, but try to moisturize that skin and optimize the circulation down to that area. That concludes cardiovascular assessment. Please let me know if you have any questions, and I look forward to seeing you in August.